You can start anytime.
I will wait 1 minute, right? Until it become 8 sharp. It's 59. So good morning or good evening or good afternoon, depending from where you are joining us today. Welcome everyone to this very special webinar on multiple sclerosis. Why it's special? Because it is scheduled today, May 30, which is the World MS Day. So today we come together to commemorate the World Multiple Sclerosis Day, which is a global initiative to raise awareness, share knowledge, and celebrate the incredible progress made in the fight against multiple sclerosis, this disabling chronic disease. And actually, this year's theme is particularly meaningful as we reflect on the significant advancement in the diagnosis and treatment that really have transformed the life of people living with multiple sclerosis. So thanks to cutting-edge research, innovative therapies, and a dedicated medical community, we are closer than ever to envisioning a future where disability from multiple sclerosis is a thing of the past and productivity and quality of life are fully restored. So I hope that you stay until the end of this webinar, and thank you for joining us as we will explore these breakthrough therapies, hear from our experts in the field of MS. We are lucky today to have Dr. Samar Faroo and Mrs. Joelle Massouh as our speaker, and celebrate all together the resilience and achievement of the MS community. Before starting this webinar by introducing our first speaker, let me thank Novartis, our sponsor for tonight, Novartis, for sponsoring our webinar today. So we will proceed and start with our first speaker, Dr. Samar Ashayeb. Dr. Samar, she's a neurologist from joining us all the way from Kuwait. She is very active in the field of MS, whether as a clinician or as a researcher. She has multiple publications in the field of multiple sclerosis, and she will be discussing today the differences in anti-CD20 medication for the treatment of MS. It is our honor to have you, Dr. Samar, with us tonight. Please start your presentation.
Hello, everyone. Thank you, Maya, for kind introduction. And it's nice to attend today in 30 May, the MS Day. And actually, the research and the new medication move the MS. And we have hope that in the future, we will have a curable treatment for multiple sclerosis, and it will be just a memory. I will go through some information about pathogenesis of multiple sclerosis and the new medications that bring hope to multiple sclerosis patient and assure the physician. MS is lifelong disease. It is, if we speak about pathogenesis, neuroinflammation and neurodegeneration that start early, even before clinical symptoms. And with time, there is more atrophy of the brain, which is an aging process for everyone. But for patients with multiple sclerosis, it will be more faster. And usually there is a new lesion. Maybe the patient and also the physician are not aware with this new lesion. According to the site of the lesion, the patient may have some symptoms and relapse, or the lesion and demyelinating become in silent area and no clinical awareness for this lesion, but still the process of pathological changes is continue. Early, there is reserve and the brain plasticity, and the brain can reserve the inflammation, but with time, this reserve lost, and with time of progression of disability, that will be motor disability, cognitive disability, and affect the quality of life of the patient. So the early disease activity in terms of relapse and MRI can predict the progression of disability. The number of relapse in the first years of onset of multiple sclerosis can predict the prediction of disability. The smaller number of relapse associated with longer time to convert to disability. However, more relapse in the first 2 years from the onset of MS lead to shorter time for EDSS6. And as you know, if the patient with EDSS6, this means that the patient needs support to walk. So more relapse, shorter time to EDSS6. Not also the relapse, also the lesion in the MRI, the number of lesion and the site of lesion. If the patient has more number of cortical lesion, this increase the possibility to go to second progressive MS after shorter time from the MS onset. So we need to treat early. Because early treatment, we can attack the inflammatory process and improve the brain reserve and avoid disability and early walking restriction. Every year, early, when you use treatment, will postpone progression of disability by more than 7%. Actually, we are as physician and also our patient now, we are lucky because we can diagnose the treatment early. So if we diagnose early, we will start the treatment early. The diagnostic criteria now, especially McDonald criteria, allow to diagnose multiple sclerosis within 1 year from the onset. As you know, to diagnose multiple sclerosis, this means we need dissemination in time and space. So if we use the very old criteria like Busser criteria, this requires 2 clinical attack, and maybe the second attack after many years, and the brain still there is neuroinflammation, neurodegeneration that not apparent as a clinical relapse, and diagnose late and start the treatment very late. But with McDonald criteria, start to become earlier because we need only objective finding, and then with time depend on MRI even after single relapse with the help of MRI and OCB and the more recent criteria that is published in 2023. Even without the OCP positive, we can diagnose now multiple sclerosis after the first clinical attack, so we can treat early. Now we have also more information and new update about the pathogenesis of multiple sclerosis over the last few years. Early in the past, we know that multiple sclerosis is a T-cell disease. But with time, we become more educated about the pathogenesis of multiple sclerosis, and we know the importance of B cells and its role in multiple sclerosis. And you notice that the drug that act on B cell depleting like rituximab showed good effect with the treatment of multiple sclerosis. And with the investigation and the research, we found how this B cell is required for the experimental model of multiple sclerosis. And we can know the role in the active chronic progressive MS. And from the beginning, OCB is very important to confirm the diagnosis of multiple sclerosis, which is B cell oligoclonal bands. Then, the function of B cells is very important. B cell has two roles, inflammatory and regulatory. Inflammatory because B cell present antigen to T cell, activate T cell, release of inflammatory cytokines, initiate complement cascade, destruction of the cell, or produce antibodies that lead to cell lysis. And it also B cell has a regulatory function, can control the inflammatory cells of T cells, control the inflammatory cytokines and produce neutrophilic factor, which is protective. So if there is balance, we can have MS in remission. And if we have drugs that provide this balance between inflammatory and regulatory, it will be a good drug for multiple sclerosis. As you know from the physiology and pathology, B cell it is produced inside the bone marrow and activated in the lymphoid organs like spleen and lymph node. Activated B cells across the blood-brain barrier, and we can see in the parenchyma, meninges, CSF, and with progressive MS, we can found the follicles of which is rich in B cells. So what are specific rules of B cell in the pathogenesis of multiple sclerosis? First of all, it is antigen presentation to activate T cells and produce inflammatory cytokines that lead to destruction of the oligodendrocyte and the myelin. It also produces B cell by itself inflammatory cytokines that activate the macrophage and lead to again cell destruction. It can be differentiated into antibodies that lead to cell lysis, and especially in the progressive stage can form lymphoid structure near the meninges, especially in the secondary progressive multiple sclerosis. And this cartoon can summarize the role of B cells among multiple sclerosis patients. We can B cell in the parenchyma, in the meninges, inside the CSF, and during active stage of multiple sclerosis, this represents the blood vessels, and this below is the B cells abundant, and this is the meninges and the follicles lymphoid-like structure, which is rich in B cells, especially in progressive stage. So B cells has a very important role in the MS pathology even before the onset. It has role in the infectious mononucleosis and the EB virus. It helps in diagnosis, OCP correlated with the lesion and with the progression of MS. B cell can predict early progression of multiple sclerosis. So there is very important receptor on B cells, which is CD19. It is a protein, and it is formed of two lobules, short and long. And this receptor control are highly effective against multiple sclerosis. So the drugs that act on CD20, how it function? Through three mechanisms. Initiate complex cascade and activate membrane attack complex. This leads to hole in and the destruction of the cell, or produce antibodies
Dr. Samar, we are not hearing you. Dr. Samar, you are muted. Please remove your mute. We are not hearing you.
Okay.
So please, just if you can repeat the beginning of the slide because you were muted. Thank you.
This one, the previous one.
Yes, the previous one and this one.
Okay. Sorry. From this slide. Okay.
Yes, okay.
Okay, so the ideal anti-CD20 that can remove the inflammatory B cells but preserve the regulatory B cells. That is important for the humoral immune system, and we need it to protect us from infection or any abnormal cells like tumor cells. So B cell come from bone marrow, this stem cell, and then differentiated and activated in the circulation. The cells, B cells that only contain the receptors CD20, these cells are affected by the monoclonal antibodies against CD20. So the stem cells not affected, and the plasma cells that is important for the humoral immune system are not affected. It only depletes the cells that contain CD on the surface. And this is very important. We can get the efficacy regarding keep multiple sclerosis in remission, but this not affect our immune system, humoral system, and no increased incidence of infection. So we have different anti-CD20 now, actually, for medication that we use. But what are the difference among these anti-CD20? The first difference of the structure of this medication. Some of them contain mouse sequence and human sequence, like rituximab and ublituximab. Ocrelizumab, more human sequence, and ofatumab, which is full humanized, so less adverse event. The other difference, how they attach to CD20 receptor on the cell membrane of B cells. We can see that ofatumab can bind to short lobule and a large lobule, and this short lobule make it near to the cell membrane and affect it. Ofatumab and rituximab bind only to the large lobule. As we mentioned in the previous slide, how they have their action through complement cytotoxicity or antibody cytotoxicity. Antibody cytotoxicity release more cytokines and more inflammatory cytokines that lead to infusion reaction and adverse event. But we cannot see this if the mechanism through complement cascade, because it make hole on the cell membrane and lysis without release of these inflammatory cytokines. Rituximab exerts its mechanism by both, but more with apoptosis, and can use through CDC and EDCC. Ocrelizumab, the mechanism more through antibodies. So we have infusion reaction when we give ocrelizumab. We cannot see this with ofatumab because the mechanism of action mainly through CDC and less through EDCC. And ublituximab more antibodies, so more infusion reaction. Then regarding the T half-life and how it is eradicated for how long, we can see that ofatumab, a small dose, a short T half time, and a short time to clearance. So if any adverse event or we want to discontinue treatment due to pregnancy, it will be cleared from the circulation within maximum 12 weeks, which is shorter when compared to ocrelizumab and rituximab. Then there are two routes of administration for this medication, subcutaneous or intravenous. What are the difference among these routes of administration? When you use the drug as subcutaneous, it goes direct to the lymph node, which is the main and first site of pathogenic action in multiple sclerosis. When we give the drugs in intravenous, they affect all the lymphoid organs like spleen, like kidney, brain, and deplete B cells from all these organs. Another important difference when you use subcutaneous versus intravenous. With administration of drug of subcutaneous or intravenous, both deplete B cell significantly and early. But B cell repletion more rapid after subcutaneous compared to intravenous administration. So now we can make more differentiation of the three drugs that we use for multiple sclerosis patients. All of them are highly efficacy medication for highly active multiple sclerosis. Ofatumab approved for relapsing remitting MS. ocrelizumab for relapsing remitting and active progressive MS. Actually, rituximab is off-label, but we use similar to ocrelizumab for relapsing remitting and active progressive MS. Regarding the mechanism of action, again, ofatumab can bind for both short extracellular loop and large, and this short make it near to the cell membrane and lysis of the cells, and also it acts through complement decascade more than antibody dependent cytotoxicity, so less inflammatory cytokines. Both rituximab and ocrelizumab bind only to large lobule, not to small lobule. The dose of ofatumab subcutaneous 20 milligram every 4 weeks, and the depletion through 38 weeks only. For ocrelizumab high dose IV 600 milligram, but every 6 weeks on infusion over 4 hours. And the summary rituximab, and they take a long time to be depleted from the circulation. For ofatumab, and because of the mechanism of action, no need to give pre-medication. It is subcutaneous, can be given at home. But with ocrelizumab, as you know, it should be at the hospital or infusion room, and we should give pre-medication like steroid and antihistaminic to avoid the allergic reaction and reduce the incidence of infusion reaction. For safety, we didn't report BML with ofatumab and also with ocrelizumab, but the main adverse event with ofatumab injection-related reaction, with ocrelizumab infusion-related reaction may be with long time. There is hypogammaglobulinemia, and we need to space the dose of ocrelizumab for patients who have treatment for more than 5 years, and if they have risk of infection. If we go to network meta-analysis, both ofatumab and ocrelizumab can significantly reduce annual relapse rate and can postpone the disability. And this table can summarize that we mentioned now. Rituximab human mouse, but ocrelizumab humanized, ofatumab full human, rituximab, ocrelizumab intravenous every 6 months, ofatumab subcutaneous every month. No need to pre-medication, but we should give pre-medication with rituximab, ocrelizumab. B-cell recovery is faster in ofatumab compared to ocrelizumab and rituximab. By this, I finish my presentation, and thank you for your attendance, and ready for any question, please.
Thank you, Dr. Samar, for a very great comparison between the different anti-CD20 monoclonal antibody, and I think a lot of clinicians, nurses, pharmacists, researchers, they had this concern about what is difference between one anti-CD20 and another. So thank you for clarifying this issue. I would like to ask you if you can stay with us until the panel discussion, and then we'll take the questions all together. And now we will move to the next presentation that will be delivered by my dear Mrs. Joelle Massouh. Mrs. Massouh is currently the clinical manager of the Neurology Institute and Multiple Sclerosis Center at Harley Street Medical Center in Abu Dhabi, UAE. And she was, before that, also the nurse in charge of the Multiple Sclerosis Center at the American University in Beirut Medical Center. She has more than 13 years of clinical experience in the field of multiple sclerosis, and of course, she is a multiple sclerosis certified nurse and a specialist in the field of MS. Joelle sits on international boards for multiple sclerosis. We are honored to have her to represent us on the consortium of multiple Multiple Sclerosis Nursing or IOMSN Nursing Board as a member on this international board. And really, we are lucky to have her today. Joelle will teach us what are the counseling tips that we should give to our patients who are suffering from multiple sclerosis. It's a pleasure, Joelle, to have you with us today. Please start your presentation.
Thank you. Thank you, Maya, so much for the invitation. It's always my pleasure to join you and IVPN on World MS Day. It's becoming a yearly ritual, and it's one of the dearest rituals to my heart, honestly. Thank you. And we are celebrating World MS Day and always looking forward to finding a cure for MS, hopefully. In the meantime, we discuss how we can manage multiple sclerosis, how we can help people living with MS live their best lives in spite of the condition of having MS. Today, I had enlightening conversations with many of my patients, discussing the fact that it is World MS Day, and using that to counsel them on many issues, on wellness, on a lot of issues. It was really a beautiful teaching moment with many of my patients today. So I'm always grateful to have these conversations with people living with MS. So thank you to Dr. Samar for setting the stage, talking about the difference in these high efficacy therapies we have in MS. Interestingly, I have some slides that are common because talking about B-cell therapies, we will be sharing some slides, so I will go over them quickly. But in general, I will be talking about wellness, how to counsel our patients. So I will tell you how what kind of messages we want to give our patients. So again, I just want to thank Maya and also thank Novartis for giving us this opportunity today to talk to all healthcare professionals interested in MS and how they can, get the message better and across for their patients as well. So in the interest of time, these are my disclosures. And, when we want to think about what are the risk factors or how do we want our patients to improve their lives? First, we want to quickly talk about is MS, what are the reasons MS is increasing in our region? First, is it increasing? Yes, the prevalence of MS is increasing. Studies from our region show the increase in prevalence. There is some reasons due to better diagnosis, better diagnostic criteria, such as the new and advanced McDonald's criteria, which are now being finalized, the newer McDonald's criteria as well, but also due to prolonged survival resulting from advanced medical therapies as well, due to a direct true increase in MS incidence, but also due to the increased urbanization, which causes less sun exposure, higher body weight, increased stress, and increased smoking. All these will guide us into how should we counsel our patients to avoid things that will increase their prevalence and even worsen their disease, and not just the prevalence itself. MS in our region could be worse. Studies show that compared with recent epidemiological studies from the West, our patients had a younger mean age at onset, and they have a more aggressive and disabling MS course as well. So we conclude that MS specialists are important, of course. That includes all healthcare professionals, from neurologists to pharmacists to MS nurses, because definitely MS is a complex disease with complex symptomatology. We are all involved in all aspects of care, including taking the history, assessing our patients specifically, doing the EDSS, the Expanded Disability Status Scale, the MSFC, the Multiple Sclerosis Functional Composite, dedicated to MS patients, involvement in symptom management, patient and caregiver education, referrals, even telehealth, psychological support, case management, and coordinating the multidisciplinary care of our patients. These are some of the things we are involved in, all of us. Our patients do have complex needs. We have shown that they are younger and they have a more aggressive course. So ultimately, we have to approach this as a multidisciplinary team. We have to aim to have effective MS management in the aim of minimizing relapses and decreasing progression. The goal is to have the patient and the family at the center of our team, always remember that they are the reason we are doing this. Around them will be the rest of the members of our team. Ideally, we would like to have all of these members, but of course, not all MS centers do have the ability or the luxury of having all these members, and that's okay. We don't all live in an ideal world, but we strive to, of course. So we should have an MS neurologist or a specialist, an MS nurse, and definitely it's better if we can have an MS certified nurse, an MS pharmacist, and of course, if they are MS certified as well, such as Maya, it's even better and better. Social workers, physical therapists, support staff, speech therapists, neuropsychologists, and many other specialists accordingly, so such as urologists and other specialists needed for the care of our patients. We should aim for optimal MS management, and that does not only rely on disease modification. So yes, we are talking about disease modifying drugs, but we should not also forget that our patients, even when they are stable, they do suffer from symptoms. So we need to target symptom management as well. We need to integrate everything from their clinical findings to their MRI findings. We should not be forgetting wellness and what affects their everyday wellness as well, and their quality of life, most importantly. Wellness is not only physical; it entails all of these aspects, if we want: environmental, intellectual, social, spiritual, emotional. And our patients are not well if any of these aspects is not well. So neurologists all over, from all over regions in the world, MS specialists specifically, they came together and led what is known as the Brain Health Initiative for MS, and they came out with a brain health report and specific guidelines to give guidance on what should a brain healthy lifestyle be for MS. They came out with recommendations, and those were published a few years back, and now they are being updated, and new recommendations will be out in the next year probably. So our patients should be leading a brain healthy lifestyle. We need to counsel our patients to keep as active as they can, keep their weight under control, keep their minds active as well, watch how much they drink, avoid smoking, continue taking other medicines their doctors have prescribed. So these are key messages you need to get across to your patients. And I take every opportunity I have sitting with my patients to discuss topics like this. Even when I'm examining them, when I'm doing the MSFC for them. So when I'm doing the 8-meter walk, when I'm doing their 9-hole pec test, the upper extremity function test, the cognitive testing, the SDMT, I take this time, I'm sitting alone with the patient, and I discuss all these issues. So it's a window of opportunity. I talk about these things. I ask them, are they doing this, that? It's a mental checklist you go through. So we do that in the clinic visit when I'm with the neurologist. And if we missed out on anything, I'll open the discussion later and go through these things as well. And sometimes you are surprised. Months later, patients will come back and tell me, I started exercising because you mentioned this, a few months back, and I'm so happy you did, and I'm committed. And I would have I might have forgotten that we talked about this, and I wasn't even sure that I got through to this patient. But sometimes one word makes you get through. So never forget the importance of your counseling and your words to your patients. It's very important to always get this message across to our patients. We need to preserve brain health. They have to keep as active as they can, including aerobic fitness, including even other exercise. I'll get to that in a bit. This is associated with faster information processing and preserved brain tissue volume. They have to be keeping their weight under control as well. It has been shown that obesity is associated with higher numbers of MS lesions as compared to maintaining a healthy weight. Abdominal obesity is correlated with brain atrophy and cognitive decline as well. Exercise is key for overall health and well-being. And we're going to talk a little bit more later on about vascular health as well. So this is also associated with vascular health. Some evidence suggests it may even stimulate the regrowth of myelin. So there are studies that show that 40% of people with MS do not exercise regularly. On the other hand, we do have people with MS who are marathon runners as well. So the spectrum is wide, but we need to have people somewhere in between. We need them to get exercise as part of their daily lives. And there's a neurologist that keeps saying it should be like a prescription, just like you write a prescription for vitamin D, for even for the B cell depleting therapies, for any therapy, you should be writing a prescription for exercise for your patients. It's that important. So what can we tell our patients to do? Find any activity that they enjoy that's tailored to their level of ability, because we have patients who are ambulatory and others who are not. So it has to be tailored. For those with mobility and balance issue, they can be sitting on machines like the ellipticals, the stationary bikes. They can be good options as well. For people with more severe disability, we can consider water therapy that can be helpful in spasticity, muscle spasms, contractions. They can incorporate music, and we know how important music therapy is as well. It can help in that as well. They should be aiming to exercise 3 to 4 times per week for 20 to 30 minutes. We need to counsel our patients that they shouldn't be worrying if their symptoms worsen afterwards, because we know that there's the possibility of Uthoff's phenomenon, which if their symptoms worsen, it can be because heat can temporarily make their symptoms worse or more noticeable, but that should go away as soon as their body cools down. We should advise them to hydrate with ice cold drinks, sit in the shade, rest, and they will feel back to baseline. So we should always reassure patients that the misconception is the sun is bad for people with MS. That's not true. We need to reassure them. So, we talked a little bit about music and the importance of that as well. There's also the fact that exercise doesn't just generally make them feel better physically, it also releases endorphins as well. And there's the concept of runner's high. It will also make them feel better psychologically too. There are options for everyone. The internet is full of resources. Now we have MS societies all over the world, including here. We launched 2 years ago the National MS Society in the UAE, where we offer resources for all patients, even cycling classes and yoga classes in Dubai, in Abu Dhabi, in all the Emirates, to help patients depending on their varying levels of disability. There are even websites that, I just put some options that you can share with your patients. Some of them are, subscription only. Some of them they have free resources. There are also many physical therapists that I recommend as well, who are certified MS specialists online. They have social media pages all over Instagram, LinkedIn, where they put detailed therapies and tips for people with MS. These are valuable information that are present everywhere and for free. And they can help people follow some tips, even for people who have high levels of disability and who are on wheelchairs as well. So how to stay mobile despite disability? We can refer our patients to physical therapies, therapists, occupational therapists who can help them stay mobile with multiple assistive devices and mobility aids. We need to help our patients keep mobile as much as possible with the AFOs, ankle-foot orthosis, many devices that can be helpful and creative to help our patients. So I've seen websites and things in beta versions. Even people who have family members who have MS are developing more and more devices to help people who have foot drops or other kinds of weaknesses, lower extremity weaknesses, to help people walk and ambulate better and better as well. So this field is highly developing too. All kinds of canes to assist them, all kinds of mobility aids such as walkers as well, and wheelchairs too. Ramps, this is better even for safety, to increase safety for patients who need more and more assistance, even inside the houses where they need the assistance from floor to floor and levels, proper maneuvering methods such as the pivot maneuver. So many options for our patients as well. Now, we talked about training the body, but we need to keep the mind active as well. That's very important. We have to advise and counsel our patients regarding education. That varies depending on our patients' backgrounds, but as much as they can, they should be engaging in hobbies, things that keep their mind active, reading if they're interested in that, or even artistic and creative things such as, art therapy. Here, the National MS Society does art classes where patients can participate in that, do some free artistic painting or participate in that. And this is where they also meet other people living with MS and engage with them if they are interested in doing that. These all help to protect against cognitive problems and cognitive decline as well. So as we said, we need to exercise our brains too. And the more you exercise your brain, the more purposeful you are about it, the more cognitive reserve you can create. We can give our patients small tips like, do some mental math, use your brain instead of your phones and Apple Watch or whatever to calculate things. Be proactive about solving problems, practice games, learn something new. We always say that this is very important. If they can learn a new instrument or a new language, this is good for all of us. And even so for our people living with MS as well. Learn something new. If they tell you, I don't want to do something that's complicated, we can just give them simple tips, such as, if you want to even watch TV, you can do it purposefully. Don't just do things mindlessly. Analyze things, analyze characters, plot lines, engage in intellectual conversations with your support system. All these are good to exercise our brain. There are also apps, apps and websites. This is available everywhere. People can look those up to do some meditation or to do some brain games. These are good for everyday exercising the brain as well. Reading is very important as well. We said it stimulates the brain. They can read about anything. If they're interested to read about MS as well. There are even inspiring people living with MS who are also authors. I've been inspired to meet these people as well. And people with MS produce a lot of things. So on this World MS Day, it's really inspiring to know about their stories too, and know that they are, a lot of them are also very successful people who live despite disability. Jillian is someone who has MS and also has breast cancer, and despite that, she is a very successful author. Who published books on people living with MS, and this is her first book, a very inspiring book about the stories of people living with MS. And her second book is about the stories of caregivers of people living with MS. And the third book is about the stories of nurses who take care of people living with MS. So, suggestions for people to read and read more. Another very important tip, and this is something, if you want to take away anything, two of the most important topics I always discuss with my patients is stopping smoking and exercising. So if I had no time, let's say it's a very busy clinic day like today, two very important topics I will always talk about, especially if I haven't seen the patients in like few months, like every 6 months, let's say, which is a routine visit. I would definitely ask about these two things. Are you smoking? Are you exercising? These are very important questions. So we know that cigarette smoking, and not just cigarette at this point, smoking is so common now, so many other ways to smoke. So, we have the shisha, the vapes, so many other things. So we have to discuss everything. We have to ask about everything. Decreased brain volume in people with MS, higher relapse rates, increased disability progression, more cognitive problems, and definitely reduced survival. So we have to discuss this. And we have to tell our patients, it's my responsibility. This is what I do. It's my responsibility to tell you that this is definitely going to make your disease worse. And, because our patients will ask us, what can I do to make my disease better? And I'll tell them, this is the number one thing you can do. You should stop smoking. And then we'll give them tools to do that. So we can help them, we can refer them to smoking cessation programs if that's available at your centers, or give them resources, refer them to other places if possible, or there are online resources as well if that's not possible too. Also, we should, for a brain healthy lifestyle, we should also remember that unsafe levels of alcohol also lead to reduced survival in people living with MS. So we should also discuss that. We should also remember that people with MS can have other diseases too. Managing comorbidities is very important. We need to know that conditions such as hypertension, heart disease, diabetes can make MS worse as well. So they need to also be following up on that. Preventive healthcare is very important. They need to adhere to medical regimens and follow up on preventive healthcare. People with MS are living longer and longer, which means They are getting more and more into old age, so they can develop diseases of older age more and more. They need to follow the general healthcare recommendations for preventive healthcare, undergo whatever is needed, like mammographies, colonoscopies, all the recommended healthcare preventive strategies, and not to forget those just because they are living with MS. Sleep is very important too. We need to remind our patients to follow sleep hygiene, because sleep can affect so many things that our patients live with, such as fatigue, mental health. It's a symptom cycle or a symptom cluster. So we need to remind them of that too. Just as I said, MS symptoms can be affected by sleep and vice versa. There are a lot of symptoms as well that cause deprived sleep or deprive patients of sleep, such as when they have, urinary symptoms, when they have urinary frequency, they will get altered sleep, of course. They will not be able to sleep at night. So they need to discuss this with their team members, with their MS team. And of course, we can help them through symptomatic management. And it's a team effort, definitely. Monitoring vascular health, as we said, is very important. We know that in general, a small amount, there's brain volume loss that happens in healthy adults, but in MS, this happens faster than usual. So we need to keep vascular risk factors under check, specifically in people with MS. So, of course, we need to be monitoring all these other conditions and treating the patients, or at least making sure they are being referred to the proper healthcare providers to help them. We have to make mental health a priority. Our patients suffer from clinical depression, definitely much more than the general population. It's almost 50% of our patients deal with depression. Of course, left untreated, it can cause multiple other issues, and it can increase other symptoms too. The importance of social interaction is highlighted in a lot of studies. It also affects cognitive reserve as well. A very nice study I always like to talk about, like the importance of the social support and our perception of reality and how it's transformed by the presence of others. In a simple study or comparison, when people looked at how you judge a hill when you are standing by yourself and how you perceive it when you are standing with someone else, you perceive it as 20% steeper if you were standing if you were standing alone versus when you're standing next to a friend who is not even looking in the direction of the hill. So when you have support, you see things as less difficult or less hard. So our very perception of reality is transformed by the presence of others. So social support is very important in MS. Some other websites that I always recommend to my patients as well, and that you can recommend as well. There's shift.ms. This is a community of people with MS, for people with MS. LiveWiseMS.org also has lots of resources for MS patients. This website as well has lots of exercises as well for people on wheelchairs too. So to shift gear a little bit and to talk about counseling people in terms of treatment as well, and not just in terms of wellness and leading a brain healthy lifestyle. So a lot of our discussions center around how we advise our patients in terms of how to, sometimes they ask us about treatment decisions, sometimes they ask us about being on treatment or not. So all these difficult questions that they are going through, especially through the first year of treatment, especially when they are shifting treatment or escalating therapy, these are big decisions for our patients and they need help with these decisions sometimes. So how do we help? Do we make the decision for the patient or do we assist? It's really usually method of shared decision making, and generally it should be driven by the patient, but we should help them make an informed decision. How? By giving them really all the information, by helping them consider all the benefits and the risks in terms of safety, tolerability, convenience, the mechanism of action, if they're interested in that as well. And many patients like to talk about that too and ask about that. Cost, of course, could be an issue. So depending on the healthcare system you are part of or the country you are part of, a lot of the times the healthcare system really decides for us. So it's not a matter anymore of decision or patient decision or even healthcare, professional decision, doctor's decision or the team's decision, the coverage or the third-party payer will decide for you when there's no options anymore. So cost can be prohibitive in a lot of instances. But let's say it's not, the other things or aspects or factors come into play. Monitoring, pregnancy issues, the patient and physician experience with the drug, the response, the convenience, as we said, all of these will help us make appropriate treatment decisions. So we started this webinar today by talking about high efficacy therapies. Why? Because really this is the age where we have shifted how we treat multiple sclerosis. Timing is very critical in the treatment of MS. A lot of studies have showed that timing of high efficacy therapy and when do we start it is highly critical. Patients treated with high efficacy therapy early on had lower cumulative risk of disability progression, as we can see in this graph, as compared to people who initiated high efficacy therapy later on. So this has been shown in studies and trials, and this has really been a reason why treatment guidelines all over the world and even our menachem treatment guidelines have shifted and have allowed for the use of high efficacy therapies early on in disease and after disease onset. So for our patients who are starting B-cell depleting therapies, and in the interest of time, I will focus a little bit on ofatumumab now. What do we advise them? What do we tell them? So generally, of course, after they start, we will advise them to contact their healthcare providers for any signs of infection during treatment. We don't see a lot of that, but we have to advise them if there's any fever, chills, or any signs of infection. We, of course, screen patients for hepatitis prior to initiating patients on ofatumumab, but we definitely should advise our patients if there's any signs of reactivation after starting, of course. If patients need to take any vaccinations, we have to make sure that this is completed before initiation of B-cell depleting therapies. In general, yeah, this is can apply for rituximab, ocrelizumab, or ofatumumab, and this should be completed prior to initiating therapies. Definitely, live vaccines are not recommended when we are taking B-cell depleting therapies. So, specifically for injection-related reactions, we have to inform our patients about the signs and symptoms of injection-related reactions and hypersensitivity reactions. And usually the first injection is given under the care of a healthcare professional, preferably in general. We inform our patients that the first injection usually has the highest risk of having an injection-related reaction. Generally, it decreases after that. It occurs, as I said, within 24 hours and predominantly following the first injection. What could those examples be? Because patients are interested and they will ask you, can you give me an example? And so for patients who have experience with the interferons, and it might have been a bad experience, you will tell them it's probably nothing like that. So that because people will tell you, will I be feeling sick every other day like I did on interferons? And it's generally not really like that. It could be that they would have a little bit of redness or itching or pain at the injection site, but it's generally well tolerated. And it could happen because it could be more systemic. They could feel a little increase in temperature or headaches or myalgias. But this should be differentiated from a hypersensitivity reaction where people will feel more severe symptoms such as rash, hives, trouble breathing, or chest tightness. And those patients should be advised to seek immediate medical attention if they experience any of these side effects. And that could occur with any injection. It doesn't have to be with the first injection. And that is generally very rare. Now, to end, I will talk about a topic that's of high importance for a big population of our patients, because generally a big population of our patients is women. So more and more women with MS are becoming pregnant while receiving DMTs. And we can see with years passing, a lot of pregnancies are being more and more exposed to DMTs. So comparing from 10 years, like from 2006 to 2016, the number of pregnancies that have been exposed increased a lot. So this is a slide that was already shared by Dr. Samar, and we can see that the half-life of B-cell depleting therapies is generally not long. And when we talk about that, this helped us shift the discussion regarding being able to allow women with MS to get pregnant either while they are on treatment, when we are talking about ofatumumab, because it is a drug that you take continuously every month, or ocrelizumab, which is a drug that you will take every 6 months. So allowing women to become pregnant shortly after taking ocrelizumab. And so it has shifted from what is on the label, if you want. So the practice has shifted a lot, and we are more and more lenient in allowing women to become pregnant faster. This has made it easier for women. We are able to counsel them and allow them to live more and more easier lives, plan their pregnancy easier. This had to be done with their MS specialist, of course, and we'll also talk a little bit about breastfeeding as well. So to talk a little bit about the clearance of ofatumumab, and why it's the risk to the fetus is low specifically, and this has been from studies that showed the pregnancy outcomes following exposure to ofatumumab in patients with MS, and this is because the antibodies will not cross the placenta until week 20, and the half-life, as we said, and when the drug will be cleared, is 12 weeks. Oh, sorry. Okay. So even if patients were to take an injection here and another injection here, so if we count 12 weeks here, this is week 18, it is still probably safe at this point and very low risk to the fetus. So generally for breastfeeding, this is mostly the label. Ofatumumab could be used during breastfeeding if clinically needed. And this is what we do in practice. But also looking at more and more data and recommendations from international studies, and this is not according to the label, but these are recommendations from international studies and based on the molecules themselves and the monoclonal antibodies, and whether they are detectable in the breast milk, and they are the likelihood of the transluminal transfer. Based on all those studies, they have been deemed compatible with lactation. So we are allowing women who are receiving these drugs to be able to continue lactation as well, or resume lactation after, start lactation after delivery. So, and actually we are recommending breastfeeding for at least the first 6 months after delivery, because this is the international recommendation of the WHO. And we want actually women to follow this recommendation to be able to lead healthy lifestyles, normal lifestyles, and not to have the fact that they are resuming their disease-modifying drugs after delivery stand in the way of them building a connection with their newborn, if this is what they wish to do as well. So with this, I will end my presentation, and keeping a message of hope, and always reminding you to help your patients live despite the illness, despite multiple sclerosis, and keep the illness in its place always. So thank you.
Thank you, Joelle, for a very excellent presentation and for leaving this message of hope that we really need today during our the World MS Day. And please, I would like to ask Dr. Samar to join us for the panel discussion. So please, Dr. Samar, if you can have your camera back and unmute your microphone so we can take take the question, and I would like to encourage our attendees who are very numerous today to leave their questions in the Q&A box so we can benefit from the presence of Dr. Samar and from Joelle with us to answer all your questions. So I will start with a question for Joelle. So they are asking you about cognitive behavioral therapy. So how CBT can be adapted to address the cognitive changes and brain fog experience with people with multiple sclerosis?
Okay. So of course, this is probably like the field of psychologists and psychotherapists more, but definitely CBT is approved for the treatment of depression and psychological issues, but specifically for issues like cognitive fog and cognitive dysfunction. Now there's the advancements of cognitive rehabilitation. This is really the field that is advancing and that is really picking up. So the use of cognitive rehabilitation methods for people who are struggling with cognitive dysfunction and brain fog. First, there will be like assessment by neuropsychological experts, neuropsych experts. They will assess the patients and see, what percent of the cognitive dysfunction is due to MS and what is due to other factors. And then they will probably refer patients to cognitive rehabilitation programs. Of course, these are not widely available yet in our Arab world, but they are available abroad. And we are looking into, getting more and more the availability of this in our Arab world as well, increasing the availability.
Yeah, we hope we can have this neurocognitive therapy that will help in improving the cognitive impairment in our MS patient, because cognitive impairment is one of these symptoms even experienced before being diagnosed or early in the phase of the disease, regardless of the type, regardless whether the patient is in a relapsing remitting phase or progressive phase. Another question for Dr. Samar. So if there is any relationship between the rate of breast cancer and the use of B-cell depleting therapy. So as you know, in the pivotal trial of ocrelizumab, there were 4 cases of breast cancer in patients who received ocrelizumab. So if there is any relationship?
Okay, thank you for this question. This is very important question, and usually we have this question for most of our patients.
Yeah, true.
This reported cancer, when compared to the general population, there was no any difference. As you know, cancer breast is common, and in every family we have one patient with cancer breast. So this that reported during the clinical trials, it is accepted and similar in the general population. But with our experience and with practice, we didn't notice any increased incidence of cancer breast for female. Most of patients are females, and we didn't notice any association between use of ocrelizumab and the cancer breast.
Thank you. So I have another question, and I think Joelle and Dr. Samar, both of you, I would like to have your insight into this. So what is the adherence rate for drugs such as ofatumumab? So would those injectable once monthly has a better adherence rate for compared to oral therapies that are given usually once daily?
I would like to listen to Joanne first, because they may be more contact with the patient more than the physician.
So
I want to listen to Joanne first.
Yeah.
Well, I mean, honestly, I would say I see a good adherence with drugs such as ofatumumab. I don't see a problem, honestly, because we also see our patients routinely. So we make sure that we ensure adherence. That's always a good point. So at least 6 months, if not every 3 months, we are seeing our patients to make sure we are refilling their medications and ensuring that they are taking their drug appropriately and well in terms of injection and everything. But in general, I see a good adherence with such drugs, because in between they can really forget that they are taking anything. And despite if they forget like the first injection or the first, because there's the loading dose in the beginning when we start ofatumumab, they don't really get much side effects after, so they are really dealing well with the injection.
Okay, I think I have similar experience with my patient. Actually, we cannot compare subcutaneous with all the oral because some medication used daily and other annually. So we will exclude the the annual oral treatment because sure the adherence will be much better. But for drugs that be used on daily basis, maybe the patient forget or get born from this daily medication every 1 month will be more convenience to the patient. And for my experience, the injection site reaction, it is only noticed in the first or maximum second dose. Yani before using this medicine when launched, I thought it will show some adverse event similar to interference and the same injection related reaction, but I was surprised that the only dose and a few patients second dose, and later on when I asked my patients, they don't have this injection site reaction. So they have a good adherence with
and I think this good, very good side effect profile and safety profile
Yes,
also contribute to the very good adherence to ofatumumab treatment because patients don't experience side effect, so they take their medication.
continue to do
And
treatment.
this is very important when we are treating chronic disease where patients need to stay on treatment for life. They have to get their treatment like for a very long period of time. So really we need to give to them a safe drug that don't affect their quality of life. I have another question for Joelle, and since we are in the era of digital health and artificial intelligence, so how can technology and telehealth be leveraged to provide better counseling services to people with MS, especially those patients with disabilities who cannot come to your clinic for the follow-up visits?
Yes, honestly, this is this we can thank the pandemic for doing this for us. It did the job. The pandemic, COVID-19, it had so many bad points, of course, with the all the detrimental effects of the pandemic. But what it did, it really changed how we deal with healthcare and how we decrease unnecessary visits and how we introduce telehealth into our clinics and our medical centers. Honestly, of course, it became much more difficult for us as healthcare professionals because now in the same day, I have to use multiple ways of communication with my patients, including email, phones, actual face-to-face interactions, and WhatsApp. So you have to use all of those to talk to your patients, including Zoom platforms as well, and all the telehealth. Because sometimes we do visits via Zoom, or we communicate with all our international patients as well. So all of that in one day. Sometimes you have to use all of these techniques, and you have to leverage all of these techniques to communicate with your patients. And this is a privilege, and of course, also it makes it difficult for you because you have to be connected on all kinds of platforms. It's very difficult, but it's also a privilege to be able to help your patients in all ways.
Dr. Samar, I have a question for you. So do we have any clinical trial or real-world experience research or studies published that explored the comparative effectiveness of the different anti-CD20 or B-cell depleting therapies available for the treatment of MS? So do we have such studies?
Unfortunately, no, we don't have head-to-head trial, but maybe later on with time we can do like a retrospective study or data extracted from SMS base to compare between them. Similar, I think there is a similar study, but not for anti-CD20, for oral medication. Maybe in the future we have something for anti-CD20.
So I agree with Dr. Samar. We don't have clinical trial comparing the different B-cell depleting therapy, and also we don't have real-world data. There are some few scattered studies, small studies comparing rituximab to ocrelizumab. There are no real-world study comparing the approved B-cell depleting therapy. And I think we can announce that we are doing currently, and Dr. Samar and Joelle are part of this big studies. So we currently collected data on thousands of patients. Dr. Hani Dimasi is currently doing the statistical analysis, so we can reveal that. so of the study. So we will publish very soon the comparative efficacy of the different monoclonal antibodies and B-cell depleting therapies. Another question for you, Dr. Samar, what are the long-term side effects of the continuous use of those B-cell depleting therapy?
Okay, actually, we have a long term regarding ofatumab 10 years, and also for, ofatumab 6 years, and for ocrelizumab 10 years. And both of them showed that both drugs are safe with long-term use. And from our experience, we didn't notice any increased incidence of infection or malignancy. We use ocrelizumab since 2017, almost 7 years, and ofatumab we have short time, but so far we don't notice any incidence of infection, malignancy with long-term use.
Thank you, Dr. Samar. Joel, I come back to you with a question regarding as a counselor. So you counsel your patient, your MS patient, about medication, about the disease, about the symptoms, how to cope with this disease. So how you address the unique needs of your patient from diverse cultural and socioeconomic backgrounds, especially that you practice in Abu Dhabi, where you might encounter people from different ethnicities, from different cultural and different socioeconomic backgrounds.
Yes. I mean, yes, it's a beautiful question. I'm not sure I have the exact answer to it because it's a tough one. But I would say I developed probably experience helps a lot. You know, all the experience that you build throughout the years. Definitely dealing with people coming from different and diverse backgrounds is not easy. And as you said, it increased a lot here because here, I mean, in Lebanon, we were also a very big referral center. So we were getting people from all over the world, but not as much as diverse ethnicities as here, because here people are expats from literally all over the world. So I even see people from all kinds of ethnicities. So it's difficult because you have to understand where people are coming from and the different cultures. So I try to educate myself if there's something I don't understand. If there's a certain cultural or cultural issue, I will try to read more about it, or I will try to ask. And you know, we have to also understand the issue of taboos sometimes, because the disease can be a taboo sometimes. They don't want to disclose maybe to families, so I have to understand that. And sometimes people want to come on their own and they don't want to discuss that with families. But I think the most important thing for me, and that's the policy I will use with all my patients, is to develop a relationship of trust. And when my patients trust me, it's, I think, the recipe for success, probably.
Thank you, Joel. Yes, Dr. Samar, تفضلي.
Thank you, Joel. The key, the trust. If you build the trust with the patient, this is the key answer.
Exactly.
The therapeutic alliance with this patient. Yes, he needs to trust us in order that he speaks about his concerns, what he feels, to break this taboos concept, so he can speak up, so we can help him as a specialist. Dr. Samar, the last question for you. So do we currently have biomarkers that will help us identifying who are this patient from the beginning, from the day we diagnose the patient, who will respond to this drug versus the other, who will respond to anti-CD20, who will respond to other drugs with different mechanism of action, or even who will respond to this anti-CD20 specifically. So do we have this?
Unfortunately, we don't have. The biomarkers in clinical practice, MRI, OCP, NMO. MRI, if we consider as biomarkers, can help me about the high lesion loss, so this patient will need high efficacy medication. And the CD20 is considered as high efficacy medication. This is the only considered biomarkers that can help me, but specific which drug and or the response or later on to measure, so far we don't have these biomarkers. Maybe in the near future.
Yeah. Yeah, we hope that we can have this so we can save time for our patient and we can identify the appropriate therapy just immediately after diagnosis. But we have to say that today we are lucky. We have a lot of options. So we have more than 24 drugs approved for MS and many high efficacy medications that are able to control well the disease of the patient, like our anti-CD20 monoclonal antibody. The last question for you, Joel. Actually, I will combine two questions because they are very interesting. So the first one, what are some effective counseling strategy to help people with MS build emotional resilience? And I know you worked on resilience in MS patient as part of your thesis for your master degree. So how can you help them to build emotional resilience in the face of chronic illness? And the next question, would mindfulness sessions play a role in this?
Yes. So yes, as you said, my thesis was on resilience actually, and the findings were really very strong in terms of the importance of social support in strengthening resilience. Of course, this was moderated by depression, anxiety, and personality traits as well, but the importance of social support was key. So this is why we focus a lot on social support, on patients strengthening their social ties and social interactions. And this is why we took a lot of time after the pandemic to really help our patients pick up, because a lot of our patients were isolated due to the pandemic. And for people with MS, with mobility issues, they were really affected by that. So we had to really help them build that, pick up after. And this is resilience. It's bouncing back after dealing with a tough time, such as the pandemic, such as dealing with a diagnosis of MS and living with a chronic illness such as MS. So they really have to bounce back, and we have to help them with the presence of social support from their family, friends, significant others, and their healthcare team, which is us basically. And what was the next question? Sorry,
mindfulness sessions and mindful techniques, would they help into
I
this?
mean, I think the research is not very strong on those probably, but we know that patients appreciate those strategies a lot. So our MS societies promote and like they assist patients in such strategies, because patients really appreciate having complementary and alternative therapies. And we always say when they don't hurt or substitute therapies, it's okay to use mindfulness strategies or strategies that can help patients incorporate health or wellness. Mindfulness or meditation have been shown to really help in these needs as well.
Thank you, Joel, for answering the question, and thank you for being with us tonight. Thank you, Dr. Samar, also for joining us tonight and for explaining to us the difference between the different drugs. Thank you so much for both of you, and we hope that with further advancement in those therapies, we can reach a disease free of disability and improve significantly the quality of life of our MS patient. Thank you so much. And with no further ado, I will move to the last session today, which will be delivered by Dr. Hani Dimasi. I think I don't have to introduce him in details because you have seen Dr. Dimasi in previous webinars. Dr. Dimasi is an associate professor of biostatistics at the School of Pharmacy of the Lebanese American University, and he will speak today, or he will teach us, because we always learn from Dr. Dimasi about how to read and interpret forest plot. Dr. Dimasi, it's always an honor to have you. You can share your slide and start your presentation.
Thank you, Maya, so much. Can you hear me fine?
Yes, we can hear you perfectly well.
Okay, great.
And
can you see my screen now?
Now, yes, but it's
Okay,
towards, I think.
Yeah. I'm just gonna go all the way up.
Yeah, sure.
Okay.
Oh, but now we have the desktop back. Yeah, now it works. Yeah.
Yeah.
Okay.
Yeah. Okay. Well, thank you so much for this opportunity to be able to talk about statistics things for this wide audience. I'm always honored and humbled by the experience, and I really like this venue. So today I'm going to talk about how to read and interpret a forest plot. So I start with what I expect that I will be able to share with you. So these are the learning outcomes. Hopefully by the end, you'll be able to identify and interpret elements of forest plots, including the source and weight, the outcomes, the individual measure, the summary measure, and the test associated with forest plots. Here's my outline. We're going to start by talking about what is a forest plot for, like why do we use it? What are the elements of the forest plots? And I'm going to focus specifically on the outcome measures because I think that's what really is the meat. Also, I'm going to talk about the test associated with the forest plots, and then I'm going to end with others use or issues with forest plots. So let's jump into it. So what is a forest plot for exactly, or what is it exactly? I think the most attractive part of a forest plot is that it's a visual representation. And what it does, it presents outcomes of multiple studies that are looking at a common measures. So specifically a certain study, a certain outcome, certain disease, and it's been studied by multiple researchers. And then we want to combine all these effects together to see like what is a pooled conclusion out of all these studies. It's useful, it's easy method showing multiple studies, and it combines the effect, as I said. Typically, it's associated with meta-analysis of RCTs, but it doesn't have to be that. And hopefully the examples I'll show, there's a variety of examples that can highlight the different types. And finally, I would like to say that the name became popular in the early 2000s, although forest plots were much older than that. So moving to the second point of my presentation, what do you expect to see when you're looking at a forest plot? From my perspective, I think you ought to focus on these 6 elements: the study identification, the study size and weight, the measure of the outcome with the confidence interval, the overall, the combination of all these effects in one, the plot itself, the visual representation of the data, and finally, the test. So you're going to also need to look at the tests, see what they mean. So here's what I mean by that. Here's a plain forest plot. That's the part that shows the study. This is the part that shows the study size and weight. This is the part that shows the actual measures. This is the part that combines everything in one measure, the overall measure. This is the plot itself, the graph, visual aspects. And finally, these are tests that are associated with forest plots. Okay, so let's address these elements one by one. The first element is the study identification. Basically, it's the name of the studies that were used in the forest plot. You expect to see the primary author name and the year of publication. So I have multiple examples. Here's the first example. You can see here that there's a list of 6 studies with the primary authors and the years of publication. Here's another example. Again, you see the name of authors with publication years. So it helps you identify what studies are being represented and what year they're published. Obviously, when you're doing a forest plot, there will be an article associated with it and the methodology. They will explain how they finally end up choosing these studies, but that's not the focus of our talk today. More example, again, study names and the year of publication. But study identification can sometimes refer to the name of the trial. So if it's an RCT with multiple names, they might just put the name of the RCT, or if it's treatments, they might put the name of the treatments. So again, I'm going to show you a forest plot example. And here we're just focusing on the study names. We're going to come back to a few of these present forest plots I'm showing you. We're going to look at the other aspects. For now, don't worry about the rest. Just, go with me step by step. And as we reach the end, hopefully we will cover everything. Here's another example. Here you can see that what you're seeing is actually the drug name. Okay, so the first part is an easy part. It's just the name of the studies and the publication here. The second part is an interesting part. This is where they're going to give you the size of the study and the weight. So they're going to show you the total sample size per study, or maybe the size per group, specifically because most of our plots are based on studies that have different groups, maybe 2 groups. They're going to tell you how many, what was the sample size in group 1 and what was the sample size in group 2. If the outcome is categorical, they might also show you the number of outcome per group 1 and per group 2. But you will also see a weight. A weight is a mathematical calculation of how much this study is contributing to the overall effect. It's kind of related to the sample size, but it's not a direct measure of sample size. There are other things that come into the effect of weight. And weight usually is shown as a percentage. So if you're looking at a forest plot and you have the weights are percentages. The study with the largest percentage weight is the study that is most or more contributing. And that weight will also be impacted in the graphical representation of the effect. And I'm hopefully going to be able to show some of that. So here's an example of one of the studies that I showed you earlier. Can you hear me fine? I'm seeing my internet giving me. Maya, can you hear me fine? Am I cutting? Maya?
We can
Hello?
hear you.
We can hear you fine.
Okay. Thank you. All right. So here again, I want you just to focus on the size. So you have 2 groups, and in every group, they're showing you the total number per study and the total number of events per study. So I'm highlighting just one of them just so that you can see them. You can also see that this study contribution is 32.3% of the entire forest plot. So basically, that's the study that is the heavily taking part of the overall analysis. So that's the weight. They add up to 100%. And as I said, the weight is also reflected in the plot itself. You see these squares, bigger square, smaller square, depending on the weight. Here's another example. You have treatment and control. You can see over here, they're showing you the yes and the no per treatment and per control. So again, you can get an idea of how big is the sample size for every study. On this column, you can see the weight, again, as percentage. And you can see that larger weights, so this one is 10.2% and has a big square, whereas this one is only 3.82%, which has a smaller square. As I said, weight reflective not only on the sample size, but also on the, so you can see, for example, in this one, the one that has 3.82, the numbers are 2000s and 2000s, okay? If you compare that to the top one, which is 119 and 128, which is 5%, you would say, wow, why is this less? Well, it's because of the number of events as well. You know, it's a calculation that accounts for the event and the sample size at the same time. Okay. Then I'm going to move to the 3, 4, and 5 elements together, which as the measures, what the measures and their confidence interval, the plot itself, and the overall effect. I thought I cannot talk about each one separately. They kind of are so much related. So I'm going to talk about them all together. The plot is just a graphical representation of the measures of every individual study. And you're going to also get the overall effect, a pool effect. Like if I combine all the meta-analysis, if I combine all these studies together, what do I get? Okay, so the measure of outcome is compared between the groups, so you can compare the studies. The outcome is comparing the treatment to the placebo, and graphically you have a line, which is a vertical line, that is pointing out the no difference. So that line is the line of no difference. And I'm going to talk maybe later about this, but the point is, if the measures that you're looking in the plot, you know, these squares with the sidebars, the confidence interval, If they cross that vertical line, then they're not statistically significant. If they do not cross the line, well, they're statistically significant. So few words on the measure outcomes. The measure outcomes depend on the outcome, the dependent variable. Is it categorical or is it numerical? So that's one thing. So I'm looking at it categorically, yes, no. Or are we looking at the numerical outcome? So is it an average of BMI, for example, or is it the occurrence of side effects or not occurrence? That's one. The other thing that also plays a role on measuring the outcome is how you're going to compare the placebo to the treatment, or group 1 to group 2. Are you going to do a ratio, or are you going to do a difference? Because whether you do a ratio or difference, it will impact the reference line, the no effect line. So what I tried to do next is I tried to pile up examples of forced plots with different outcomes. And for each one of them, I tried to tell you what is the type of the outcome, what kind of comparison, and what the reference line would be. So you can see that the first 4 are all ratios, but they're not the same thing. One of them is a risk ratio, another is an odds ratio, you have an incidence rate ratio, and you have a hazard ratio. Each type is determined by the study, is determined by the kind of analysis you want to run. But all of them are categorical, and all of them, let me see if you can see my pointer, I'm hoping. So all of them, we're doing a ratio, which makes the reference line a 1. Because when you're comparing 2 things and you're doing a ratio, if they're equal, then the ratio will be equal to 1. And therefore, the reference will be 1. Then you can also be doing a risk difference or a mean difference. Okay, so instead of doing a ratio, now we're doing a subtraction between the 2. And a risk difference, the outcome is categorical. The mean difference, the outcome is numerical. But for both, the reference line will be 0. And then there are other things. I'm going to show you an example where there's no reference size because there is no comparison, actually. So let's tackle each of these examples one by one and look at what they're showing us. So here I'm starting off with the risk ratio. You can see it's a risk ratio by looking at the title over there. You have all the risk ratio per study with their confidence interval. You also have overall effect on the bottom. So if we combine all these studies together, the overall effect, the risk ratio will be 0.77, which is a reduction in the risk by about 23%. And then it comes with a confidence interval, which is from 0.66 to 0.89. Now, if we analyze these, and the reference line is at 1 here, because as I said, it's a ratio. So the measure outcome in a study are represented on the graph. As I said, you have a square that represents the risk ratio or the odds ratio, whatever it is. Usually it's a square. It doesn't have to be a square. Okay. And then the line extending are the confidence interval. The vertical line, as I said, this is the no effect. It's visually very easy for the reader to see which one is significant and which one is not. And typically the overall, the pooled effect is on the bottom, and usually it's in a diamond shape. And the diamond is right in the middle. That's where the effect value is. And the diamond is extending to the confidence interval. So again, going back to the example I was showing you, all those effect that I'm circling here, you can see that they're as they're extending with their confidence interval, they're crossing the vertical line. So all of these are not statistically significant because they're crossing the 1. This one, on the other hand, their extension is not crossing 1, and therefore it is statistically significant. And interestingly enough, if you go to the diamond, which is the overall effect, right in the middle, that's your 0.77. And the diamond extension is the confidence interval. It's not touching the line. It is statistically significant. So moving on with the different types of forced plots outcomes, that's an odds ratio. Again, an odds ratio reference would be 1 because it's a ratio. And you can see that you have different measures for every study, some of them crossing one, some of them are not. The overall is 0.53, meaning a reduction in the odds. And it's statistically significant because it's not crossing one. The last thing I want to point out is sometimes you're going to see an arrow at the side of the confidence interval. What that means is that graphically they're stopping here, but the interval is actually extending further. But they stopped because probably it's going to be too big and it's not going to be visually nice. So they're going to stop showing you where it goes, but they put an arrow just to say, well, watch out, the interval didn't stop here. The other thing I want to point out is that sometimes author, what they do is on the x-axis of the plot, they don't do a uniform. And again, they don't do a uniform because they're trying to show something that is nice to see. But you as a reader have to watch out not to be tricked by this visual distortion of the x-axis. So I'm going to show this example while looking at the incident rate ratio. Again, that's a ratio, meaning that the reference line is 1. But look at the x-axis, look at the distance between 0.5 and 1, and look at the distance between 1 and 50. Obviously, that's not a uniform x-axis. And again, they do that on purpose because they want to fit all these confidence intervals in one plot that you can visually see. So they kind of do some sort of transformation so that it becomes easier to see. More examples of outcomes. You have the hazard ratio. A hazard ratio is a ratio. So again, the reference line is going to be 1. Now here the authors decided not only they're going to show you the plot, but they also decided to give you the p-values. So if you look at these two studies, the line are crossing the 1. And indeed, if you look at their p-value is non-statistically significant. So you're kind of getting like the same information different ways. One times it's numerical value, one time it's a graphical value. Moving along with more examples of outcome. Here you have a risk difference. So as I said, if it's a risk difference, then the reference line is going to be the 0. And you will see that the overall effect is clearly shown. It's negative. It can be negative because of the difference. So there is a reduction in the risk. And the diamond is not touching the 1. It is statistically significant. Here's an example looking at the mean difference. Okay, so again, when you're looking at the mean difference, the reference is going to be 0. You have the individual means with their confidence intervals, some of them crossing 1, some of them are not. The overall effect shown as a diamond. All right. Now, that's a very interesting first plot because this one is looking at prevalences using different studies. And there are no different groups. They're not comparing groups. They're saying, okay, they're looking at the difference of certain outcome, prevalence of certain outcome. And every study is showing a different prevalence, okay? So can I combine all these studies to get one overall? Yes, you can. And that's what you're seeing in the diamond. Again, I want to point out that here, there is no reference line because we're not comparing. We're just trying to come up with an overall effect, which in this example, they're calling the pooled. Pool meaning that you're pooling all these studies together to get one overall effect. More examples. So this is the last example I'm going to show about a type of measured outcome that you want to present. These are diagnostics accuracy. So how good is this diagnostic tool to diagnose a certain outcome? You may be familiar with the two concepts, the sensitivity, meaning sensitivity of 80%, meaning that 80% of those that have the disease will actually be testing positive. Whereas specificity is like if you have a 90% specificity, 90% of those that are healthy will have a negative test. And again, here what they're showing is that these different studies with different sensitivity and specificities, and they're comparing them in terms of where they are in values and how much variability there is in each one of them. There is no reference line because you're not comparing between groups. Kind of the same idea, sensitivity and specificity here. The only thing I'm showing that is not present in the previous slide is that there is a summary estimate. right? There is this overall effect, the combination, and they put the dot line just to show you like where would be the overall effect. Okay, so we finished part 1, part 2, 3, 4, and 5. We're left with the last part, which is the test, the statistical test. Typically, there are 2 statistical tests that you expect to see in a forced plot. One is the overall effect, which we kind of know the answer now that we know that the overall effect is presented by this diamond. And we know that if the diamond doesn't cross the reference line, that it is statistically significant. But what they do is they also provide you with a z-test with the null hypothesis saying no overall effect. And therefore, if your p-value is less than 5%, less than 0.05, then this means there is statistically significant effect and the overall effect is significant. The other test that you expect to see is the homogeneity or heterogeneity. I mean, they refer to it as the heterogeneity test. It's a chi-square. And the null hypothesis is that there is no heterogeneity. And I'm going to talk about these 2 tests in the coming few slides. So that's a slide where I'm going to point out the overall test. You can see it right there. It's a z-test, and it has a p-value of 0.003. It's less than 5%. It is statistically significant. And actually, this is also seen when you look at the overall, the effect, and the diamond is not crossing the 0, I mean. The confidence interval 1.83 to 8.65 is not crossing the 1, statistically significant. You're getting the same message one time with the test with the p-value, the other time with the confidence interval and a graphical display. I want to point out that the overall effect has more power than the individual studies, and that's kind of the idea of why we're pulling these. So one major advantage of doing meta-analysis, which is the kind of analysis we do when we're running a forced plot, is that by combining all these studies that may not have been powered enough, you can get, very powerful overall effect. And it drives the power, this overall effect drives its power by combining the small sample size with one big sample size. I want to point out that you may have all the individual or the majority of the individual studies not statistically significant, but the overall is statistically significant, and you shouldn't be surprised. That's totally normal. And that's kind of why the idea of doing meta-analysis, combining these small studies together to get a strong study. And when you have more power, not only you're reaching statistical significance, but also your interval is going to get narrower. So I'm going to show you, here's another example. Here's the overall effect with a p-value less than 0.0001, which is very statistically significant. You can see it again visually on the graph with the white diamond. Let's move on maybe to the most challenging part of the forced plot, test of heterogeneity. So what does it mean? Well, the concept stems from the fact that the overall effect, when you're combining all these studies, well, you're getting different studies together and you're combining them into one. And obviously, these different studies are not giving you same values, right? Each one has a different value. And the question is, why are we getting different values? Is it a natural variation, chance only? Or is it that there is something else playing? Something else, like maybe biases in the studies or methodological issue in the studies. So it's not a chance that is making the studies different, but there's something else. When there is something else, we say there is heterogeneity. How can we test this heterogeneity? Well, you can assess this heterogeneity in 3 ways. One way is just eyeballing the graph and looking at the individual effect and see how much they're far away from one another versus they kind of like lining up. The second thing, there is actually a chi-square that is testing the heterogeneity with a p-value. As I said, the null hypothesis is that there is no heterogeneity. So if your p-value is big, it means that there is no heterogeneity. Whereas if your p-value is small, it means there is heterogeneity. The third method is the I-square. And I-square is some sort of a percentage of heterogeneity. The bigger the I-square, the more heterogeneity there is. And here's a guideline that is used by authors. If you have an I-squared between 0% and 40%, there's no heterogeneity. 30 to 60%, then, heterogeneity, you're getting into the moderate effect of heterogeneity. 50 to 90, well, here you probably have a heterogeneity, and 75% and above, then there's considerable heterogeneity. There is another rule of thumb that says your I-squared has to be less than 40%. Anything above 40%, then you have heterogeneity. So let me show you the example. Here you can see that there is a test of heterogeneity, which is a chi-square, and that chi-square has a p-value of 0.45. That's a big p-value, meaning we are failing to reject the null hypothesis of no heterogeneity. And that is furthermore substantiated by the I-square, and the I-square is 0%. It's very, very low. Okay? Then the conclusion here is that there is no heterogeneity. Whereas in this one, if you look at I-square, the I-square is 92.22%, which is very large. And therefore, there is a lot of heterogeneity. And if you actually eyeball the data, you can see, some of the values are on one side, some of the values are on the other side. I can actually add more squares here. You can see that they're not lining up as much. And one thing I want to point out is that when you have heterogeneity, the method of analysis is called the random effect model. So that brings me to my next slide. If there is heterogeneity, can we still calculate an overall effect? The answer is yes, using the random effect model. So if you're ever looking at a forest plot and you read random effect model, it means there is heterogeneity. It means that these values you're looking at, their variation is not only due to chance, there's something else. And therefore, to account for that, they use this method. But if there is no heterogeneity, then you may see that they write something called the fixed effect model. Okay, so covering all the major aspects of forest plot, we still have few issues. We can use forest plot for subgroup analysis. You can see here they have multiple studies, and they're combining them for children, for adolescents, for adults, for elderly. They're kind of doing like separate forest plots. And if you do it this way, you will notice that the older you get, the more effect you have. This is another also subgroup analysis. And here I would just want to point out that notice how they put on the x-axis, and this is a trend, on which side is favoring what treatment. And again, this is a method that helps the reader, understand better the results. Sometimes you have one study with a lot of outcomes, and you can combine them in a forest plot. So here's a study where you have the annual relapse rate done in 3 different analyses. Okay, you have the GD plus lesion also done in 3 different analyses, and you have a hazard ratio representing that. And you also have the NIDA-3 analysis. And again, it's done through an odds ratio. And you can see that for each one of them, you're indicated which treatment is better so that you can interpret the results easier. Final use of forest plot is in network meta-analysis. In network meta-analysis, you don't have head-to-head. You're going to compare everything to one treatment. So all of these are being compared to one treatment only, which is the main treatment. You can see that all these treatments, the main treatment is doing better. For these ones, there is no statistical impact. The point of network meta-analysis is that you don't require to have a head-to-head RCTs to be able to do this. So in conclusion, forest plots are a useful tool to present visually a synthesis of multiple studies. They provide users with easy to use and interpret pooled results to support evidence-based decision. Before I finish up, let's do a practice test. Try to see if you can answer these questions with me. So question 1, if you're looking at this forest plot, how many studies are we comparing? So 1, 2, 3. 3 studies. Which of these studies is contributing the most to these results? So 1, 2, 3. The first study, the weight is 55.8. What is the measure of outcome that was utilized in the study? So again, the odds ratio. Any of these studies were statistically significant? And the answer is no. None of them is statistically significant. They're all crossing the one. Last question. What about the overall effect? Is it statistically significant? Yes, it is. It's not crossing the one. The Z p-value is 0.04. And I think I may have one more question. Is there heterogeneity or not? And the answer is the chi-square p-value is 0.69. The I2, which is the percentage heterogeneity, is 0. There is no heterogeneity. And that's why you can see here, there is a fixed effect, as I mentioned. Okay, that's it for me. Thank you for listening. I really want to thank Maya Zainuddin, and I want to also thank the IVPN NeuroPsychiatry Network. And I also would like to thank Novartis for this opportunity to talk to all of you today. It's really a great opportunity. Thank you so much. And I'm going to stick around if you have questions.
Thank you, Dr. Dimasi, for an excellent presentation. I think we all benefit from it. So I have, yes, actually a few questions for you. So the first question, so I will start from the last concept to discuss, which is heterogeneity. So how can we address heterogeneity when we are planning to do a meta-analysis initially? So when planning the study, how can you address the heterogeneity in meta-analysis?
Okay, so I'm gonna try to give you an answer. First, you may be aware that there is specific guidelines to follow when you're doing a meta-analysis in terms of what studies get in and what studies do not get in, what kind of methodologies, is it a double blind, etc. So you may have all of these that help you reduce the noise. Also, there is something called a bias analysis that is done part of the meta-analysis, which is some sort of a matrix where you go study by study and you're seeing how heavy the bias is in every study. Having said that, measuring heterogeneity is a statistical concept. It's measured using statistical techniques. It's like modeling with they're checking if there is an extra element. And which is fortunate for us, you know, you can check statistically if there is heterogeneity or not. And the good news is, even if you have heterogeneity, it doesn't mean you cannot get a combined effect. Remember, heterogeneity means that the differences between these studies is due to chance plus something else, meaning that originally there is a common effect, but when you're measuring these studies, there is a noise in each one of them. So we're trying to cancel out the noise. And therefore, using the random effect model helps reduce this noise. I hope I answered your question.
Yeah, perfectly. Another question, so what strategies can be employed to ensure diverse participation of to ensure diversity in the sample or in the sample population in multiple sclerosis research study? So how can you ensure diversity?
I think, Maya, you're more equipped to answer this question. You have much more experience than me in running multiple sclerosis studies. Do you want to answer that, please, on my behalf?
So really, diversity is not always needed when conducting MS study. On the other hand, we usually set specific diagnostic criteria. So we set cut-off age. What are the phenotype of MS we are studying? So whether patient with relapsing remitting MS, progressive, or both. We specify what is the level of disability for those patients. So really, we not always we have to diversify, except if we are talking about epidemiological studies where we are looking at the epidemiology of the disease, the knowledge, the quality of life. Here, yes, we need a diverse pool of patients. But whenever we talk about clinical trials or real-world studies for medications, for therapies, for diagnostic criteria, really diversifying the sample size, the sample population is not a good idea. I hope I answered the question. Another question for you, Dr. Dimasi, is there a difference, or how can you differentiate between statistical significance and clinical significance when interpreting a forest plot in general?
Okay, so I think here the best thing to do is you have to collaborate with your collaborators, including your clinician, your statistician. Your statistical partner is going to help you interpret how much the statistical significance is heavily dependent on large sample size. So you may have a very large sample size and you're finding significance. But then you're looking at effect and you're wondering, well, is this really meaningful? And that's where your clinician is going to help you, like a reduction in risk of 4%. It may be very statistically significant, but clinically wise, does it make that sense? It depends on the disease, I guess.
Yeah, and depend on the disease, it depends on the outcome exactly that we are measuring. So probably, for example, a minor change in ADSS won't be significant, whereas a new lesion on MRI, one lesion might be of clinical significance. So it depends.
Great example, Maya. Thank you so much.
On the outcome we are evaluating. The last question for you, Dr. Dimasi, before we close the webinar. So do we have software or program that you recommend for generating and analyzing forest plots?
Well, that's a good question. The last time I looked into it, I couldn't find anything except for Excel. And we were having a presentation not too long ago by physicians where they did a forest plot. And I asked this question because I'm wondering if they did it Excel. The way Excel does it, it's not straightforward. What you have to do is you have to start with a bar chart, but it's a sideways bar chart. And then you have to put your interval, and then you have to remove your bar chart and just keep the interval with it. It's kind of like doing a lot of steps. You end up with very nice forest plot. But I wish, I looked into it last time, and you remember, Maya, we were building the forest plot, and that's the only way I'm sure there is, but I personally couldn't find. Thank you for the question.
Thank you, Dr. Dimasi, for
thank you.
This very insightful presentation and session. Thank you so much. So let me end this webinar by thanking all three of you, our esteemed speaker, Mrs. Joelle Massouh, Dr. Samar Farouk, and Dr. Dimasi. Also, I would like to thank our very numerous attendees who attended and joined our webinar today. And of course, special thanks to our speakers for their valuable insight. We really hope that you found this session informative and inspiring. I would like to invite you to stay connected with us and follow our social media platform where all our future events, announcement for our future event will be posted. And actually, the third episode of Building Clinical and Research Confidence in MS is scheduled on June 20. So stay tuned for another successful episode. And also I received a lot of questions from you asking about if the session is recorded. Yes, actually the session is recorded, and you can access the recording of this webinar by visiting our IVPN library, which is currently available free of charge, where you can revisit this webinar and all our previous webinars. And finally, I hope that we continue to support our MS patient and advocate for our MS patient and their caregivers, not only during the MS Day, during May 30, but throughout all the days of the year, because really our MS patient needs our support and of advocacy every day. I think together we can make a difference. Thank you very much for our sponsor for also bringing us all those high efficacy DMT so we can improve the quality of care and the quality of life of our MS patient. Thank you so much, everybody. Stay tuned and have a good night.
Good night, everyone. Thank you, Maya.
Thank you, Habibti.
Bye-bye.
Bye.
Thank you.